Thank you very much for those of you who have, stayed. I know it's the late part of the day, and a lot of information through the morning. So thank you for staying. So we are now to the last session. We have three speakers, and each one would spend about 10 to 15 minutes presenting their topic, and then we'll call them to the podium and then take some questions and answers. Okay, so the first presenter is going to be Dr. Hawthorne Smith. He's online. Dr. Hawthorne Smith is online, okay. Dr. Smith is the director of the Bellevue Program for Survivors of Torture and president, National Consortium of Torture Treatment Programs, who is also joining us virtually. That is his speech. He's going to be talking about wisdom, courage, and hope, effective interdisciplinary care for survivors of torture and forced migrant populations. And then followed by that, we'll have Ms. Crystal Miller. She's here. She's a holistic practitioner and clinical psychotherapist at Melanated Masks, right? That's correct. And then after that, we'll have Dr. Briggs, Asa T. Briggs, psychiatric nurse practitioner at Briggs Psychiatry and Behavioral Health. Will give his talk at the end. And at the end, I'll call them to the podium. I will take some questions and answers. So we'll start with you, Dr. Smith. Please go ahead.
Thank you so very much. And
15 minutes.
I want to thank the coordinators of this edifying and informative program for including me. And I salute you on behalf of the Bellevue Program, Survivors of Torture, and the NCTTP. I have no disclosures in terms of financial links with pharmaceutical companies, but I will say I have a significant amount of pharmaceuticals coursing through my body right now. I just had hip replacement surgery 2 days ago. That's why I'm not with you in person, but I did not feel that this was a conference that I could miss. So I just want to thank you folks. So again, I do represent the Bellevue Program for Survivors of Torture. We were founded in 1995, and to date we have treated more than 6,000, close to 7,000 survivors from all over the world. I think now we have actually crossed the barrier of 120 different countries worldwide. Our mission is to help rebuild bodies, the minds, the spirits of people who have been tortured, persecuted. And one of the things I just wanted to point out is that, as you see from these pictures, and Bellevue with its old history, but it's also a very modern hospital, that we really do value evidence-based practice. But we do not want to throw out the cultural wisdom, the practice-based evidence that we have acquired over the course of the years. We don't always have the luxury of placebos or control groups or what have you. And the focus on our interdisciplinary approach. And I think that this is what might make this most valuable to those of you coming from different domains. And the other thing is that we really take a resilience-based, strength-based approach to our clients. And we feel that our clients are survivors, which is much more than being victims. We feel that anybody can be a victim. Wrong time, wrong circumstance, wrong place. But to be a survivor is really more about a comportment, a real sort of validation of their strength and effort to hold on to the sense of humanity, even though it has been violent and purposely attacked. Next slide, please. Oftentimes, when I have more time, I would go through a number of these questions, and I start by asking people, have you ever voted in an election? Have you written an editorial, blah, 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 and I go through some of these things you see here. And maybe people will look at me kind of funny, like at the beginning of a presentation like this, who is this guy asking all these intrusive, borderline, inappropriate questions, perhaps? But the reason I do it is because if you can raise your hand or nod your head to any of these questions, if you identify as a woman, if you do have a sexual orientation that is other than heterosexual, any of these things that are here, oftentimes I am asked, who are these torture survivors? It's almost as though they are considered to be this sort of exotic other population. But if you could raise your hand, if you could nod your head to any of these or many other questions I could ask, I can honestly say that the people we are treating are people just like you, just like us. This is not about an exotic other. This is about us. This is about a sense of shared humanity and people who are facing such significant challenges. Next slide. So, among the challenges experienced, and again, it's a challenge to go through so much of the domain within 15 minutes. I'm going to try and do this so you get a sense of the context in which the treatment takes place, but also to really look at some of the ways and some of the best practices. So I'm going to go quickly. I'm going to do that New York thing. That we are not just dealing with PTSD, even though it's a very useful diagnosis at times. That we are looking at people who have been through social dislocation, whether that's been a rebel insurgency, a civil war, homophobic persecution, race-based persecution, whatever it might be, being in prison, perhaps escaping, living as an IDP, an internally displaced person in their country. Oftentimes escaping and making it across the border to another country where there might also be chaotic, impoverished conditions and where they might be seen as infiltrators or might be a xenophobic response. And then somehow making it to this country. We look at many people leaving West Africa and going by Pirogue and trying to get to Europe. People who are coming into Brazil, coming into Ecuador, and then making their way up through Latin America, crossing the Darien Gap, and just the trials and tribulations to even make it to our southern border, and then the political and social realities that they're facing now. And then coming to New York City and trying to engage, trying to adapt with us in New York and all of our infamous warmth and fuzziness. We are not talking about something that is post. We are talking about recurring, reinforcing stressors that really do serve to keep the trauma alive in the present. And the multiple losses and challenges that people are facing. And they will respond to this in many, many different ways. And we will get into that, but I just want you to understand this is about us. It's not about a particularly bad day back in the Democratic Republic of Congo. It is about recurrent and reinforcing stressors that we're dealing with today. Next slide, please. So physical and emotional scars. Oftentimes when I do this presentation with one of our PCPs or medical professionals and we have the quote unquote gory slide show or what have you, we're not doing that. But what I want to talk about is the interplay. That many times those of you who are medical practitioners might have someone in your office who is expressing some sort of paresthesia, some sort of physical response, but there's no etiology that you can determine, but it might really be from their emotional comportment and the trauma that they have gone through. It might also be that with the physical trauma they have gone through, we have had clients who have talked to us and said that some of these wounds might heal, these physical wounds or what have you, but oftentimes what is the most deeply felt are the emotional wounds. When someone talks about a mock execution and thinking that their life is gone, when we talk about someone who has gone through torture, but now is going through the asylum process and has been separated from their children for 6 or 7 years, that sort of pain, that oftentimes the emotional pain is even more indelible than the physical, but they work and really fuse and serve to multiply one another. So we want you to just really, again, think about this not as things happening in silos, but just multiple ways in which people are challenged. Next slide. So this slide gets a little bit more into it. These are many of the ways that people respond to torture, to refugee trauma, and I could put a lot more lobes on this flout if I had sort of stronger PowerPoint skills. But what I want you to really see is that it's not that the cognitive is over there, the physical is this way, the emotional is somewhere back there. They all fuse together, and we live, for lack of a better word, in the center of this flout, where one thing really can reinforce the other. So for example, if somebody is having nightmares or dealing with insomnia because of the trauma they went through, they may wake up in the morning feeling really tired, low energy, perhaps there are headaches, they might miss appointments with you, or they might come in late, or they're not able to hold down their job. These sort of ongoing social stressors can reinforce rumination. There might be difficulty in learning new things, that we can talk about the nature of traumatic memories and what trauma does to our ability to sort of capture new information, if we talk a little bit more. Frustration, depressive symptoms, this might lead to self-medication or some sort of maladaptive coping strategies. So for example, if someone says to me that they drink 1 or 2 beers a night, and that helps them get to sleep, for a sort of quote unquote typical New Yorker, okay, maybe that's not a big thing. But if this is someone who comes from the Muslim tradition, and I will say Eid Mubarak to all of you who are celebrating Tabaski and all of that this evening, this weekend, that someone drinking 2 beers a day, which is haram, has great meaning to them. So again, all of these things are working together and sort of buffeting the person. And so this is part of the bad news, is that at the individual level, there are so many stressors. Next slide, please. And then even in terms of how one might engage in relationships. And this will manifest itself when we are seeing patients in our practices. What is their ability to process information? What is their ability or even willingness to talk about memories with you? Can they relate to you? Do they relate with others? What do they think about the future? What are their feelings about the world? So sometimes we might put labels on this person is resistant, or this person is reticent to engage. But is it really about that? Or is it about the way that trauma has really impacted their ability to interact with others? Next slide, please. And then if we take it a step further in terms of the spheres of marginalization in a more sort of societal sense, educational functioning. When I got my doctorate, it was a big thing in my extended family. I was one of the first to do so. But if things hit the fan here in this country and I'm forced to flee to Haiti, let's say, not only am I no longer Dr. Smith, but my Creole is so non-existent that I become functionally illiterate. So again, this sort of levels of disempowerment. Legal advocacy. In our program, more than 90% of our clients who come to us are dealing with the asylum process, where they sort of have to engage in the legal system, even to claim their right to be here. The vocational, the professional, as our clients will let you never know who's driving your Uber or your Lyft, who's sweeping your floor, who's standing guard outside the 99-cent store in the middle of the winter. Many of the clients that we work with were targeted because of their leadership roles within their societies. And they were chased because of that, and now might be living as the 14th person in a 1-bedroom apartment. And social functioning, the way people are treated in schools and different things, there's a lot to be said here, but again, I'm going very quickly. So let's go to the next slide. Now, the previous slide showed about so many different ways that our clients are challenged. This one shows many different ways that we can approach healing. And again, making an impact in any one of these modes feeds back to the middle, so that someone receiving medical services at our clinic, they might not be interested in behavioral health services at first. Maybe they're not familiar with it, or maybe it is actually stigmatized in their home culture. But if they actually begin to see that, hey, I'm getting some tangible benefit from this program, and one of our medical providers says, hey, you seem to be really isolated, you're a French-speaking African survivor. Dr. Smith runs an ongoing support group for French-speaking African survivors. This might be useful for you. We begin to sort of work that way. When we look at the social and legal support, oftentimes in our program, the longest line is outside of our social and legal service providers. It's nice that I'm feeling better pain-wise, that I'm sleeping a bit better. I've met with the psychiatrist, but how am I going to normalize my status? How am I going to get my family here? And I'm proud to report that our success level for our clients who have applied for asylum now stands at 95%. We have helped more than 1,400 people get their asylum. But again, we can make a difference in any one of these areas. It makes a difference across the board. So the bad news is that there are so many challenges they're facing, but the good news is that there are so many ways to intervene across disciplines. And for those of us who are not practicing health care providers, I would say it doesn't have to be therapy to be therapeutic. Next slide, please. I was in Pittsburgh in 2018 after the vicious attacks at the synagogue there, and we were having community meetings dealing with some of the societal trauma. And one of the things that really struck me is that one of the attending physicians there talked about the general review of systems. that one learns in medical school and through practice. But he said, we need to expand our review of systems to be also a review of experiences, a review of context, a review of feelings, any way that we can really, again, make this an interdisciplinary approach where behavioral health issues and are not sort of separate, they're not a side dish. The founder of our program at Bellevue, Dr. Alan Keller, he always says if he had one question to ask, and he's a primary care physician, it would be, how are you sleeping? It's open-ended, it's direct, it's medically linked, but it opens the door to so many different ways of approaching if someone's dealing with nightmares, if they're having sleep interruption, if they can't sleep at night because they're so afraid they can only do so during the daytime. It's one of these things that we can do to help normalize the conversation. As you well know, the patient is the prime expert in terms of the pain they are actually feeling. We need to have that humility mixed with our expertise to learn from them so that we can move forward. Next slide. So, two of the things I just want to point out in terms of treatment priorities and techniques. One is around safety, one is around empowerment. Bellevue is very much like Kings County. I think that if you look up in Wikipedia and say, large, urban, chaotic hospital, what have you, and, this big picture kind of jumps out. Anything that we can do to help reduce the ambiguity, to make our physical environment more inviting for folks, but to reduce the ambiguity, what is it that we can provide? What can they expect from us? What are we expecting from them when they come to meet from us? Anticipatory guidance, again, letting them know what it is we can provide and helping to build trust. And very brief anecdote with this. I worked with a woman from Cameroon over 20 years ago, and this is someone who came from a fairly elite family. She actually had bodyguards from the time she was a child to the time she was a young adult. And when there was an attempted coup, a reversal of power, the people who actually turned on her were her bodyguards. So we were talking about trust and developing a trusting relationship. And she made it very clear to me that there was nothing I could do to earn her trust. She said, even if you say all the right things, even if you do all the right things, and you do them for 20 years, that's what my bodyguards did. But ultimately, they are the ones who betrayed me. So there's nothing you can do to earn my trust. I responded with silence. One, I thought it was appropriate. Two, I had nothing. But she thought about it some more, and she said, even though you may not be able to earn my trust, perhaps it's something I can offer because I really need the help. And it's something that really crystallizes in my mind. It changed the way that I approach what we do, in the sense that, yes, there is nothing I can do to earn someone's trust. There's plenty I can do to destroy their trust, but I need to accept their trust as a precious gift that is being offered and to cherish it as such. In terms of empowerment, again, putting ourselves in a place where we are working collaboratively with our clients as opposed to this expert sort of stance. Again, these are not just victims, these are survivors. Where does this strength come from? What is it that we can learn from them? Allowing them to teach and to share. Again, I work at a program where we've seen people from 120 different countries, and I will say there is no possible way to be an expert in country conditions in 120 different spaces. And I will say even more, there's no way to be an expert in one place to the level that that person sitting across from us is. Even if we have our own immigration experience from the same country, our experience is not theirs, and we need to be in a position to learn. And sometimes when we're doing, things, and I do most of my service provision in French, other languages, but when we're dealing with someone who is speaking to us in English, maybe English is their fourth or fifth language, and they might have feelings about it because they're not fluent. To even just put forth that as someone born in this country, as a proud American, I can say that I come from a country where we barely speak one language. And my in-laws in the UK will tell us, yeah, it's not English. I don't know what you New Yorkers are doing, but that is not English. And also just to point out, hey, if we were doing this in my fourth or fifth language, it would be a really short interview. So if I just might ask someone what languages they speak, and they say, oh, I speak Pular, I learned Quranic Arabic, I understand some Malinke, the colonial language is French, and I'm learning English, any way to help raise them in the hierarchy and let them know that they are valued and valuable. Next slide, please. And that we need to really alter, or at least be willing to consider altering how we engage with folks around the cultural norms. One of the things that we, I think, take a lead on at Bellevue in this field is around groups. I've been running a group for French-speaking African survivors. We're into our 29th year at this point, and it's gone beyond being a therapeutic group to really something they call la famille africaine, or even the baobab. And for those who are familiar in the village setting, sometimes it's the baobab, l'arbre à palabre, literally the tree of words, where people come together to share their experiences, to get advice and what have you. And by engaging this way, oftentimes people are more amenable to other services. It helps to give them a bond. And as they mentioned, and I think it's a Native American expression that sorrow shared is halved, while joy shared is doubled. And it really helps our clients as well to understand that they are more than just people who are needy. They are people who are needy. They are part and parcel of the healing experiences for others. Next slide, please. So just a few things, and I'll just grab a couple from here. Character versus circumstances. Many of our clients, as I said, have had so many losses, so many stressors. Maybe they're having difficulty learning English, even though they already speak so many different languages. There's a trauma speaks so much, but oftentimes we're able to talk about the notion of their character, the fact that they were intelligent people at home, if they were generous people at home, if they were socially oriented people. All of that remains. They're still intelligent. They are still generous, even if they don't have 2 cents to rub together right now like they used to. Socially oriented. The circumstances might change, but the more we can work to hold on to character, the better place we are to really engage and help to change the circumstances in a better way. You can never say, oh, things will be like they were before. If I do, I'm exaggerating, I'm going much too far. But I think that it's important. And the fact that this is a hard journey, it is, there's a lot of hard work involved, and what many of my French speakers will say is like, rien n'est facile, mais tout est possible. Nothing is easy, but everything is possible. And providing this sort of notion of hope is really beginning. And next slide, and my last slide, I hope I didn't go too fast or too slow, but this is where the title of my talk comes from. I was running a group session. Again, this is more than 2 decades ago. And there was a formerly enslaved person from Mauritania who was having a really rough time. And his family was in hiding. The asylum process was going much too slowly. Frustration was there. And he asked the question, what are the qualities? What are the characteristics that we need to change the world, or at least to survive in this world? And I thought that this is such a profound question. This group will never come up with a consensus. And I was wrong, as I frequently am. And the 9 people who were there that night, they came up with 3 things: la sagesse, le courage, et l'espoir. Wisdom, courage, and hope. And they went further. And they said that if we have 2 of these 3 qualities, no matter which 2, it's insufficient. Because if you're a courageous and hopeful person, but you lack wisdom, chances are you're going to go about your activities in a way that's ineffective. You'll fail. Conversely, if you're wise and hopeful, but you lack courage, you will never act on your volition. You'll never go forward with the things you need to do, and you'll be trapped in a prison of inertia. But as you've heard all day today, and I hope you get a sense from my talk, the wisdom is there. And I'm not just talking about advanced studies, but a cultural wisdom, education de base, as they would say, the courage to think about the things people have gone through, to come all the way here and start over at zero. We don't even have to talk about courage. But what is hard to hold on to is hope. And I thought that was it, but they went even further and they said, Dr. Smith, you have to understand that hope is not so much something you have, it's something you do. It is actually an active capacity to hope. It's an attitude, it's a comportment, it's a discipline. And they said that perhaps the most important thing is that that capacity to hope is something that can be shared. And when it's shared, then the people can use the wisdom and the courage they already have. Blew my mind. I remember it like it was yesterday. And it changed how I view what we do in the group, what we do in our program. And I think that what we do across our disciplines, in certain ways, we are in the business of sharing the capacity to hope so that people can use intrinsic wisdom and courage they already possess. And with that, let me again say thank you for having me, and I look forward to any questions you have.